Okay, the great thing about someone who's on a long time trach is they learn to speak using a trach. The way they do that is the cuff is deflated on the trach. They put a cap on the um, trach itself on the outside. They put what's called a Passy-Muir valve. That goes on the hub of the trach. It's a one-way valve. Air goes in, but air does not come out of that. And the patients learn to um, take air in and push the air up through the throat to use their vocal cords and learn to speak. When patients first start this, it's very anxious causing, anxiety causing. They first have a hard time doing this. It just feels wrong with not having that air come back out. So they have to practice using this, but it actually works pretty good, and then the um, patient can start learning to speak. So when the trach is removed, you got a stoma there. So how do we clean stomas? Everybody remember? Just warm water. Don't put any alcohol on that. So basically, they would just put a steri strip over the trach stoma. Patient needs to learn if they're going to cough to cover that with their hand, and they don't suture it. It just basically closes on its own. Okay, let's talk about acute bronchitis. Acute bronchitis lasts 10 to 20 days. We've all had bronchitis. Usually you have clear sputum and you just cough your head off horribly. Can't stop coughing. Obviously, shortness of breath the more you cough, and on exertion. Acute bronchitis will not have consolidation on x-ray or infiltrates. The way you can discern bronchitis from pneumonia is pneumonia will have consolidation and infiltrates. So these patients need a lot of rest. They can use cough suppressants, bronchodilators, medications. If it's viral, which they probably most of them are, Tamiflu, but it must be started within 48 hours. So Tamiflu, you start early. Don't do it when you've already got these symptoms. Chronic bronchitis is cough and sputum for at least 3 months in each of 2 consecutive years. So some people probably have chronic bronchitis, but they really don't think they do because it only happens during the winter time. But if this is what they have chronic bronchitis. Obviously, damp weather, colder weather will aggravate this. So chronic bronchitis, you have a hypersecretion of mucus and inflammation. The walls thicken, the bronchioles, and you have the lumen, it thickens, lumen narrows, hard to breathe. It causes obstruction. These patients are called blue bloaters because they have high CO2 because they can't get out the air. So these people usually have barrel chests, and we call them blue bloaters because their CO2 is much higher than normal. So what causes this? Well, history of smoking, a lot of respiratory infections, exposure to irritants, so chemicals, things like that can cause it. Also, a long history of smoking combined with a patient who also has COPD or emphysema. A lot of these patients also have chronic bronchitis as well. So, productive cough in the winter months. The cough is exacerbated by cold weather, dampness, the irritants. Sometimes pollen can cause this, anything. So it all depends on the patient. They have a lot of shortness of breath. So what do we teach the patients to do? Treatments, well, lots of fluid intake because fluid will liquefy the mucus more. Try to eliminate the irritants. Don't be around them. If it's secondhand smoke, then don't be around secondhand smoke. Somebody who's really bad, maybe they need to move to a warmer climate, or during the winter go down south. So that will change the shift in humidity and temperature is the thing that usually causes it. Patients need to learn to cough, do deeper coughing, better breathing techniques if they have this. Medications, if it's bacterial at all or fungal that's causing the issue or the irritant, then antibiotics, antifungals, bronchodilators, steroids. Those can help as well. Here's a picture of your normal bronchi and then bronchitis, much smaller lumen with lots of mucus buildup. Bronchiectasis. This is a permanent dilation of your medium-sized bronchi. It's caused by multiple infections or infections that were never treated. So basically, these patients, because it's really dilated, they have a hard time breathing up mucus from their lungs. They also have a decreased expiratory airflow. If you have them take a very deep breath and blow it out, they just can't blow out a lot of air. So the air basically just sits there, which obviously would increase a higher risk of infection and problems in their lungs. Hemoptysis can occur. It doesn't happen with everybody, but it can if it gets bad enough. So treatment. These patients try to get that fluid out is a lot like a cystic fibrosis patient. Physiotherapy, postural drainage. Physiotherapy is wearing that vest that vibrates. That helps loosen up the mucus. Laying the patients on one side and the other is postural drainage. If a patient has hemoptysis, they start coughing up blood, not just a little spot, but really coughing up blood, you need to elevate the head of the bed and place the patient bleeding side down. Well, if it's coming from the lung, you really don't know unless the doctor already knows the patient and knows which side of the lung they're bleeding on. But anyway, that's the best thing to do. These patients need to drink lots of fluid, if those that have bronchiectasis, because that mucus needs to come out. So the recommendation is the patient should drink 3 liters a day. If they only drink half a liter a day, you don't want them all of a sudden drinking 3 liters, because they could go into water toxicity. So you build yourself up, just increase by an extra glass a day is your goal. So just increase it. Patients should also be on low sodium diets. So remember, fluid follows salt. So low sodium diet will help decrease the amount of fluid that may be gathering and causing the mucus. So pertussis, we hear pertussis with children. Pertussis can be caused by, it can be in adults. It's more common. They're beginning to think that people that have the DPT shots, they don't last as long or they just break down. So it's a bacterial infection. If you've heard this cough, it's very, it's got its own characteristics, like a whooping sound and then gasping for breath to breathe back in. It happens more at night. It lasts 6 to 10 weeks because it is a bacterial. We're going to treat them with a macrolide, so the mycin drugs. And a cough suppressant is not going to help these patients. So that is not something that's going to help them, and they need to get the medication. Pneumonia. So in our lungs and throat, we have certain mechanisms that help so we don't get bacteria, fungals, irritants in our throat and lungs. We basically breathe through our nose, so we filter the air. It also warms and humidifies. We have the epiglottis that closes over our trachea when we eat. We have a cough reflex to bring stuff back. We have what's called the mucociliary escalator, that basically those little fine hairs that are always moving to bring stuff up from our lungs. So those should be working. So we also have secretion of immunoglobulin A to help fight bacteria. And then we have the macrophages. Interestingly, somebody who smokes, that mucociliary escalator mechanism, when they smoke, it stops working. It just basically kills it. So the reason you see smokers all of a sudden wake up in the morning and have a smoker's cough, is they're like, oh my gosh, I'm coughing my head off, I need a cigarette. Well, sure you need a cigarette because during the night there was enough time you weren't smoking that the mucociliary started working and they started moving things, and that makes you cough when you wake up because it's doing its natural job, and you want to quickly have a cigarette to deaden that so it's not causing a cough. So smoking's basically causing the natural mechanism in the lungs. So pneumonia, basically air sacs fill up with fluid, they fill up with mucus down there in the alveoli. So there they are. You can't expand air, you can't do the exchange of your CO2 and oxygen. It's basically going to stop that. So risk factors. Risk factors are huge. Oh my gosh. Just aging because our lungs just don't work as well. Air pollution. Horrible air pollution can cause a risk for pneumonia because you're taking all that irritants and toxins, chemicals when you're breathing. Altered consciousness. Patients that have had a stroke, they've OD'd, they passed out from drinking, they've had an head injury, they can't swallow very well. These are all risks because patients can aspirate. They can all aspirate with these things. So aspiration pneumonia is very common, especially with anybody with an altered consciousness or aging population as well. Patients on bed rest, prolonged immobility. That's why we get patients up so early after surgery. We don't want to develop pneumonia. So using the IS treatment. Patients with chronic illnesses, diseases, lung diseases to begin with. They've already got emphysema, they've got bronchitis, COPD, heart disease. Heart disease affects fluid in your lungs, renal disease, cancer. A lot of chronic illnesses are going to play a part. Patients that have suppressed immune system, like HIV/AIDS patients, cancer patients, anybody taking immunosuppressive drugs, or those diseases that are caused by deficient immune systems. Inhalation, aspiration. Patients that have nasogastric tubes or intestinal tubes for feeding, they have a high risk of aspiration because of those. Smoking obviously is a risk. Being tracheally intubated, so there is a specific kind of pneumonia called ventilator-acquired pneumonia, VAP, that's in critical care. Those have to be guarded very carefully. And patients with upper respiratory tract infections, patients with asthma, patients with allergic to different things. There's basically three kinds of pneumonia. One of them is community acquired. You acquired it out in the community. Hospital acquired pneumonia, two kinds basically. Ventilator associated pneumonia, not acquired, so ventilator associated pneumonia, VAP. Those usually come on greater than 48 hours after intubation. JACO, Medicare, CMS track this. Hospitals get dinged if patients come down with ventilator-associated pneumonia. They will not pay for that treatment. So there's certain protocols that are done for these patients. They do not acquire ventilator-associated pneumonia. Associated pneumonia, healthcare associated, meaning while you're in the hospital, while you're in a rest home, assisted living. These are more serious because if you're acquiring pneumonia while in a healthcare facility, the chances of it being a very virulent pneumonia are higher. Pneumonia that's not going to be able to be treated as easily. Could be medication the meds just aren't taking care of it. So they're very more drug-resistant organisms. Then we have aspiration pneumonia that can happen anywhere, at home or in the hospital, but that's usually caused by aspirating. And then opportunistic pneumonia, patients that have HIV/AIDS acquire what's called opportunistic diseases. So that's the cause of that one.